Hi, my name is Tiffany Gill and I'm a Senior Research Fellow with the Registry of Senior Australians based at SAMRI and the University of Adelaide. Welcome to my talk on the impact of musculoskeletal conditions on assessed levels of care required by older Australians. I'd like to acknowledge my co-authors, Steve Westling and Maria Ignacio. Musculoskeletal problems, including conditions such as back pain, neck pain, rheumatoid arthritis, gout and osteoarthritis are common in the population. They rank highly in terms of global disease burden, particularly in terms of morbidity. Age is a common risk factor for many of them, and it's likely that older people assessed for admission to residential aged care have a musculoskeletal condition. The objectives of this study were to examine the prevalence of musculoskeletal conditions among those undergoing assessment for admission to residential aged care. And for those receiving no assistance or community care only following the assessment, examine the associations with selected co-occurring chronic conditions, health risk factors, and functional limitations. The study used data from the National Historical Cohort of the Registry of Senior Australians, otherwise known as ROSA. ROSA is an Australian clinical quality registry designed to monitor and evaluate the health, service use, medication use, mortality and other outcomes of people receiving aged care services across Australia. ROSA brings together existing information from state and Commonwealth governments in order to provide a complete picture of how individuals navigate the health and aged care sectors. An aged care assessment team member delivers a ROSA information sheet to a potential participant. The aged care seeker has the option to opt out from ROSA. The data sources include the National Death Index, the PBS, the MBS, and the National Aged Care Data Clearinghouse. There are also linkages with hospitalisation data, emergency department data, and ambulance services data. The target population is the historical cohort of 2.9 million Australians and the prospective cohort of South Australians having an ACAT assessment. The domains cover population, aged care service utilisation, and healthcare services utilisation. Outputs include research, risk profiling tools, annual reports including an outcome monitoring system, and there is also significant consumer engagement and activity. The focus of this study, as I mentioned, is the historical cohort of 2.9 million Australians, 1.2 million of whom have an ACAT. Participants who received an aged care assessment between the 1st of July 2004 and June 30th, 2014 were included in the analysis. This was a cohort of approximately 1 million people. Logistic regressions were used to determine factors associated with receiving community care only or no assistance among those with a musculoskeletal condition compared to those who were admitted to residential aged care. An activity limitation is deemed to be any activity where assistance or supervision of another person is required in order to accomplish the activity. These are categorised as yes or no. The activity limitations determined from the aged care assessment include walking, at or away from home, self-care, social and community participation, transport, domestic assistance, communication, healthcare tasks, home maintenance, meals, and movement activities. Overall, 51.9% of participants were admitted to permanent residential aged care, and of these, 40.2% had a musculoskeletal condition. Of those not admitted to residential care, 56.7% received no assistance, 16% received community care only, and approximately a quarter received transition and/or respite care. Among those who received no assistance, 43.5% had a musculoskeletal condition, and about half of the community care only group had a musculoskeletal condition. The multivariable analysis compared those with a musculoskeletal condition who received community care only to those with a musculoskeletal condition in residential aged care. The community care group were more likely to be female, living with family, have a limitation with social activities, domestic tasks, home maintenance. They were also more likely to have cancer, obesity, cardiac conditions, and pain. A second multivariable analysis compared those with a musculoskeletal condition who received no assistance to those in residential aged care. Those who received no assistance were more likely to live with family or others, have a limitation with domestic tasks, home maintenance, or none of the activity limitations. They were also more likely to have cancer, obesity, cardiac conditions, or pain. Data from this study allows us to determine, from the perspective of those with musculoskeletal conditions, the services that are accessed following an aged care assessment. Those with musculoskeletal conditions receiving community care or no assistance were actually less likely to have dementia and other activity limitations such as feeding or self-care, which supports the fact that those with greater care needs are more likely to be admitted to residential care. However, when compared to those with musculoskeletal conditions in residential aged care, the community care group and the no assistance group had very similar characteristics. These include both activity limitations and chronic conditions. There were also relatively few people who received community care compared to the group who received no care. The reasons behind the differences in access to care need to be examined. It may be that there are differences in how the need for support for older people are determined. Aged care assessment teams are comprised of a range of health professionals who may have differing perspectives on the support required. Potentially, the availability of services in an area may also influence how people are assessed, and this may raise the issue of equity of access. I'd like to acknowledge the Healthy Ageing Research Consortium investigator team and ROSA's research team at SAMRI. I'd also like to acknowledge the funding that's been received for ROSA. The Australian Institute of Health and Welfare needs to be acknowledged for the linkage and construction of the input data, and SA Health for the provision of the state-based hospitalisation data. ROSA has a number of partners, and these are shown on this slide, and the contacts are also available here. If you would like any further information, please feel free to contact us. Thank you.